Very good evening, friends. We are going to discuss today about the postoperative pulmonary complications. And postoperative pulmonary complications are very common and very costly to treat and increase the patient's morbidity and mortality. What is the definition? What is the definition of postoperative pulmonary complication? We are day-to-day activity. We are facing this postoperative pulmonary complications, and we should have to improve our knowledge regarding this postoperative pulmonary complications, whom to occur, when to occur, who are the patient at risk, and how to tackle the situation, what are the preventive strategies, and these are all the scope of the lecture today. And by the way, what is the biology? What is the definition of this postoperative pulmonary complication? And any complication affecting the respiratory system after anesthesia and surgery. So this is the very simple definition of postoperative pulmonary complication. And why they are occurring? Why they are occurring? We have to go into the details of this question. And who are the patient at risk? And what is the impact and incidence of postoperative pulmonary complication? And what are the strategies to prevent this postoperative pulmonary complication? Because the morbidity, it affects the morbidity and mortality of the patient also. So postoperative pulmonary, we should have the adequate knowledge regarding this postoperative pulmonary complications. And the incidents, there are more than 230 million major surgeries are done worldwide today. And among these surgeries, 1 to 23%, there is a large variable percentage of incidents of PPC occur in the world. And the most common postoperative pulmonary complication is postoperative respiratory failure. It's the most common complication. And what is the impact of this PPC? That is taken from the Annals of Surgery 2005. It increases the morbidity and mortality of the patient. It increases the morbidity and mortality of the patient. And these incidence ranges from 1 to 33%, I have already told earlier. And the patient will die, 15 to 30% of the patients will die within 30 days of the major surgery. And will also prolong the length of hospital stay from 13 to 17 days. And that will cause the increased healthcare costs also. So cost effective also. That is why the developing PPC also increase the healthcare costs primarily as the result of increased length of hospital stay. And this EPCO, what are the entities in PPC? And starting from this infection to death of the patient, there are 14 entities in PPC. It is the respiratory failure, pneumonia, respiratory infection, pleural effusion, atelectasis, pneumothorax, bronchospasm, and aspiration pneumonitis, ARDS, tracheobronchitis, pulmonary edema, exacerbation of pre-existing lung disease, and pulmonary embolism and death of the patient. With these entities, an EPCO, that is European Joint Task Force, published guidelines for perioperative clinical outcome definition. And how will you define this patient with respiratory failure? How will you define this pneumonia in PPC? How will you define pleural effusion and atelectasis in PPC? These are guidelines are there by the European Task Force. If you say this respiratory failure, the postoperative PaO2 is less than 60 millimeter of mercury on your room air, and PaO2 to FiO2 ratio is less than 300, and arterial oxyhemoglobin saturation measured with the pulse oximetry is less than 90% and requiring oxygen therapy. These are the definition by the Task Force of European Society. And for this respiratory infection is concerned, antibiotics for suspected infection within one or more of the following new or changed sputum, and new or changed lung opacities, fever, white blood cell count is more than 12,000. And regarding this atelectasis, there is a lung opacification with the mediastinal shift, hilum of the hemidiaphragm shift towards the affected area with the compensatory hyperinflation in the adjacent non-atelectatic lung. So when we say diagnosis, the pneumonia, one of the most common postoperative complication, and we should have the definition of pneumonia in PPC, and with a CXR with at least one of the following. There should be an infiltrate or on consolidation or on cavitation. There should be a finding in a CXR, chest X-ray. And with this, plus at least one of the following criteria should be there. That is, a fever more than 38 degrees centigrade with no other cause, and WHB count of between less than 4,000 or more than 12,000, and age more than 70 years with altered mental status with no other cause, plus at least two of the following. There should be a new prolent or changed sputum or increased secretions, suctioning, and new or worse cough, dyspnea, tachypnea, rales, bronchial buzz sounds, worsening of gaseous exchange. So these are all the categories to be met out to diagnose the pneumonia in postoperative pulmonary situation. And these are all the risk factors, perioperative, preoperative, intraoperative risk factors for the development of the postoperative pulmonary complication. Of the age is the most single independent risk factor, that is more than 60 years, and ASA grade of 2 and more, people are more prone for PPC. It's a very good evidence. Journal evidence, literature evidence is there. That is why it was written as a good in bracket. And functional dependency of the patient. It's a very, those who are functionally dependent, they are more prone for PPC. And patient with comorbids like congestive cardiac failure, COPD, they have a very good evidence. Those patients are more prone for PPC. And smoking is a fair evidence, and recent respiratory, upper respiratory tract infections, and OSA, obstructive sleep apnea syndrome, pulmonary hypertension, delirium, patient with alcohol use, and weight loss more than 10%, and disseminated cancer. These are all the risk factors for the development of PPC in the postoperative period. And intraoperative risk factors are surgical factors. Any surgery, prolonged surgery is having more than 3 hours duration, has a very good evidence to develop PPC. And surgical site, the site of the surgery has the very important role in development of the PPC. Then abdominal, major abdominal surgeries, thoracic surgeries, and neurosurgeries, vascular and head and neck surgeries, they have the very good evidence, literature evidence to development of PPC. And the anesthetic factors, general anesthesia is a highly more prone and independent factor for the development of PPC. And neuromuscular blockade drugs, they are used in our general anesthesia with residual neuromuscular blockade, all leading to PPC. And this is for this evidence I have already told to diagnose respiratory failure as per the definition of European Task Force, and postoperative PO2 level is less than 60 millimeter of mercury on room air with ABG finding, and PO2 ratio less than 300, and SpO2 less than 90% in the room air requiring oxygen therapy. And these are some of the lab evidences are considered as the risk factors for the development of PPC. That is, serum albumin level less than 3 gram is a very good evidence as per the literature from Cleveland Clinical Journal of Medicine 2009, and hemoglobin less than 10 gram is a fair evidence, and SpO2 level less than 96% in room air is a fair evidence. Any abnormality in the CX or chest radiograph is a fair evidence, and increase in renal parameters of serum creatinine and urea. They have the insufficient data, but they are all the risk factors for the development of PPC as per the literature. And the pathophysiology of PPC, regarding this, there are intraoperative risk factors are there. And I have already told earlier, general anesthesia is the independent factor. It will cause central respiratory drive depressed, causing prolonged apnea, followed by return of spontaneous ventilation with a dose-dependent reduction in minute ventilation. And the ventilative response to hypercapnia and hypoxia are significantly impaired at low doses of anesthetic drugs. And any airway obstruction occurs, and there is a respiratory muscle function changes immediately after induction of anesthesia. An airway obstruction occurs, and there is increased curvature of the spine and cephaloid diaphragmatic displacement in dependent areas, and lead on to atelectasis and reduce the cross-sectional area of the chest wall. These changes in end expiratory muscle tone occur irrespective of whether or not the patient receives neuromuscular blocking agents or not. So that will lead on to reduction in the functional residual capacity of less than 15 to 20% of the initial with the patient and supine position, and this reduced the FRC along with the abnormal distribution of ventilation during intermittent positive pressure ventilation, lead on to V by Q mismatch, and there is increased areas of high V by Q and low V by Q ratios, and there is a definite significant reduction in the lung volume, especially this FRC, lead on to development of atelectasis. The physiological factors that will lead on to development of atelectasis are direct compression of the diaphragm due to displaced diaphragm. An airway closure occurs because FRC is come down and it is lower than this closing volume, and there is a rapid absorption of gases from the alveoli in the lung regions where the airways are narrowed or closed. And last of these three factors exacerbated by the use of high fractional FiO2, that is called that lead on to absorption atelectasis. When you use this FiO2 of 1 during this induction of anesthesia, and all the alveoli filled with 100% oxygen with the FiO2 of 1, and lead on to absorption of this oxygen in the alveoli, lead on to collapse of the alveoli. There are some of the CT evidence, there are some studies in the literature shows that immediately after the induction of this general anesthesia, the dependent portions of the alveoli are going for atelectasis. This is the CT finding. And this hyperoxia, that is FiO2 of 1, that lead on to development of atelectasis in dependent portions of the lung. So that suggests that high FiO2 pre-oxygenation is the independent risk factor, and for the prevention, 20% air oxygen mixture with air of 20% nitrogen with oxygen, and preventing alveolar collapse. So avoiding 100% oxygen will prevent atelectasis, and maintaining the moderate level of positive pressure, airway pressure during expiration to maintain the airway patency. And other one is this intermittent airway positive pressure ventilation when prevented, and this ARM, that is alveolar recruitment maneuvers, are required to expand the collapsed alveoli, re-expand the alveoli. And other factors, surgical factors, already told, more prolonged surgeries. And this prolonged surgery, prolonged anesthesia lead out to depressed alveolar macrophage function and interference with the surfactant production and reduced mucociliary clearance and increased permeability of the alveolar capillary barrier. And these other surgeries where the surgery is going on, and the site of surgery has an important role for the development of PPC. Major surgeries in head and neck, abdominal, aortic aneurysmal surgery, thoracic surgeries, neurosurgeries. And other risk factor is one of the important risk factors, nasogastric tube has been shown to be a risk factor in PPC in the postoperative period, increasing the risk of micro aspiration. Occurs and 4 to 8 times higher in patients with NGT in the postoperative period. And this postoperative pathology, posterior anesthesia care unit changes that lead on to airway obstruction occurs in many patients, exacerbated by continued sedation from residual anesthetics and opioid drugs, and from hypercapnia contribute to continuing central respiratory depression. And the residual neuromuscular blocking drug effects, and there is an impaired response to hypoxia and hypercarbia in the postoperative period. So this residual neuromuscular blocking drugs will produce impairment in the normal phasic activity of the genioglossus, the muscle which has the tonicity of the tongue is maintained by this genioglossus. So the coordination of pharyngeal and upper esophageal muscles are abnormal, increasing the risk of aspiration. And ataclasia is still present in patients with PSU. And it was significant. I have told earlier that it was significantly worse if the patient received 100% oxygen during emergence. And ataclasia and CT scan 24 hours after surgery is also more common in morbidly obese patients that lead on to alveolar to arterial gradient difference that remains substantially elevated 1 hour after extubation of the patients. Those who having major surgery and indicating significant venous admixture. So because of the use of this NMBD, neuromuscular blocking drugs, the inability to re-expand atelectasis during the first few hours of the major surgery. After the dose of NM neuromuscular blocking drugs, it takes longer for the patient to recover inspiratory, re-inspiratory strength and coordination, and then to recover normal respiratory expiratory activity, demonstrated by reduced FEC and FEV1. After abdominal surgery, after take home message. That FRC, when it returns to normal after general anesthesia, very minor surgeries, usually FRC return to normal within 24 hours. But in upper abdominal surgeries, FRC reaches to lowest value and return to normal after 5 to 7 days. So ataclasia is seen in CT scan during anesthesia persists for there up to 7 days in the post PSU. If the PSU patients, we can keep the patient for 1 or 2 days, and after stabilization we can shift the patient for surgery, the wards. But the atelectasis persists up to 7 days. It will not recover. Collapse alveoli is maintained. So because of this atelectasis, the effort dependent lung function test, FEC, FEV1, and peak expiratory flow rate are significantly reduced. The normal activity of the most respiratory muscles is impaired after major surgery, including the airway muscles, abdominal muscles, and diaphragm. These are all the most important muscles to maintain the normal tidal ventilation. So the factors contributing to dysfunction include the anesthetic agents, neuromuscular blocking drugs, postoperative analgesic drugs, particularly opioids, and pain, and disturbed sleep patterns in the postoperative period, and the inflammatory response to surgery. These are all the most important contributing factors that lead on to this impairment of the above muscles, which are all most important to maintain the normal tidal ventilation. Usually, the respiratory control may be abnormal for some weeks after anesthesia and surgery. That is why there is an impaired ventilatory responses to hypercarbia and hypoxia. The studies are there in literature says that the responses were still slightly impaired for 6 weeks after surgery in major surgeries. That study shows. At the time when inflammation, pain, and analgesia are usually absent, and the response to hypoxia and hypercarbia is much more delayed. It may be persist up to 6 weeks. And sputum retention is very common after surgery. General anesthesia, particularly with a tracheal tube, causes impairment of mucociliary impairment, and there is transport of the secretions that may persist in the postoperative period. So there is a combination of reduction in FRC, residual atelectasis, and inactive cough and abnormal respiratory control forms an ideal situation for PPC to develop. I repeat again, the reduction in FRC, residual atelectasis, ineffective cough, and abnormal respiratory control forms an ideal situation for the development of PPC. So there are preoperative for this, you have to make a risk stratification for all the patients more prone for the development of PPC. We have to stratify them. That is by the pre-op risk stratification prediction models are there. That is Scott having the 7 variable regression model, and that is the next one is the periscope. That is a regression prediction models that has the simplified modification the Scott, and the independent variables are low preoperative peripheral oxygen saturation, SpO2 less than 96%, and there is a respiratory infection with the last month, and age of the patient, preoperative anemia, and intrathoracic or upper abdominal surgery, and duration of the procedure more than 2 hours, emerging surgeries. These are all taken as an variable variables are taken into to stratify the risk stratification in the prediction models. And who gets PPC? Can the risk stratification, we can come to the conclusion that we can segregate these risk factors in the modifiable and non-modifiable. And the modifiable, non-modifiable patient risk factors are the age of the patient, male sex are more prone, and ASA with a more than 2, and functional dependent patient, and patient with a respiratory infection, impaired cognition, impaired sensorium, cerebrovascular accident, malignancy, weight loss more than 10%, long-term use of steroids, and prolonged hospitalization. We cannot modify these risk factors. We have to accept as it is. And we can modify these risk factors: smoking, COPD, asthma, congestive cardiac failure, sleep obstructive apnea syndrome, and BMI of the patient between 18 to 40, less than 18 and more than 40, and hypertension, chronic liver disease, and liver failure, ascites, diabetes, alcohol, GRD, preoperative sepsis, preoperative shock. These are all the modifiable patient risk factors. We can modify them. So these comorbids are present. We have to optimize the patient before submitting the patient for surgery. And these non-modifiable procedure factors, I have already told earlier, the type of surgery where it is done: upper abdominal, aortic aneurysm, thoracic surgeries, neurosurgeries, head and neck, vascular. These are all non-modifiable. Elective emergency surgeries, we cannot do anything. And duration of the procedure, we cannot modify it. And resurgeries, very worst thing for the development of PPC. And multiple GA during admission. These are all the factors we have to take into consideration. And modifiable risk factors or mechanical ventilation strategies, we can modify it according to the patient. And general anesthesia, we can modify it. We can switch out to regional. We can prevent PPC. And long-acting neuromuscular blockers, we can change out to short-acting. And this assessment of neuromuscular block in the postoperative period, we can change out intermediate acting NMBDs. And neostigmine use and reversal with scumodex with supraglottic airway devices without intubating the patient. And use of these peripheral nerve stimulators and open abdominal surgeries, perioperative NG tubes and intraoperative blood transfusion. These are all we can modify it for the development of PPC. So we can go into this modifiable risk factors and management. Regarding these comorbidities, I already told you have to optimize the patient before subjecting the patient for surgery. If there is respiratory infection, you have to control it. And if it is selective, we can stop the surgery for 4 to 6 weeks. We can postpone the surgery. And perioperative steroid replacement for those on high dose oral steroids should be considered. And congestive cardiac failure, we have to treat them. And next one is the smoking. Smoking has the very large impact on the respiratory system. There is the impact on the almost all the systems of our body. But regarding this respiratory system is concerned, it has a more effect on this. It has decreases the ciliary motility, increases the sputum production, and area reactivity is very high, and increase the pulmonary proteolytic enzymes and release of elastrolytic enzymes lead on to damage of the parenchyma, lead on to emphysema. And there is a release of reactive metabolic oxygen-free radicals that will damage the lung and increase the epithelial permeability and reduce the surfactants in the lung and will increase the carboxyhemoglobin level. So carboxyhemoglobin is more affectionate with our hemoglobin. The affinity is 210 times the normal of our oxygen, and almost most of our hemoglobin is saturated with carboxyhemoglobin, and oxygen carrying capacity is drastically reduced with carboxyhemoglobinemia. And this smoking reduces the immune function, lead on to infection. And smoking in the RS, respiratory system is concerned, single most independent factor for the development of lung carcinoma and chronic obstructive pulmonary disease and development of atelectasis in postoperative period. And infection, postoperative pneumonia is very, very common with smoking persons, patient with a history of smoking. So we have to stop smoking at least for 4 to 6 weeks in case of elective surgeries. Definitely the most important strategy to be followed. And the next one is the preoperative anemia. Preoperative anemia, the hemoglobin should be not less than 10 gram if we are subjecting the patient for major surgeries. So because the anemia, preoperative anemia is has the 3 to 5-fold increase in the risk of PPC. And this autologous blood transfusion also have the independent risk factor for the development of PPC. So erythropoietin is another option, but you have to correct the anemia before subjecting the patient for major surgeries are at least concerned. And erythropoietin is another option, but it has associated with the development of PPC. And general anesthesia, we have already discussed in a very detailed way. So general anesthesia is an independent risk factor for the development of PPC. and the duration of surgery is also important. And OSA also, obstructive sleep apnea syndrome, it's a great nuisance and great problem for the anesthetists and the patients also in the perioperative period. Lead on to these patients are very sensitive to opioids and they are more prone for PPC, especially acute respiratory failure, both combined, type 1 and type 2, combined failure in patient with OSA. So what are all the strategies to prevent this PPC? The lung protective ventilations that involves tidal volume and PEEP and recruitment maneuvers. That studies the most current expert recommendation for non-obese patient for lungs with normal lungs subjected for major surgeries. The most important recommendations are low tidal volume with a 68 ml per kg with a PEEP value of 2 centimeter. But that is the recommendation in a normal lungs. But we can optimize the PEEP according to the situation is concerned. That is called optimal PEEP. And the FiO2 should be 0.4, maintain the FiO2 0.4. And if the SpO2 is maintained more than 92%, and the FiO2, increasing the FiO2, there is more chance for development of atelectasis. And the respiratory rate, we have to titrate according to the carbon dioxide levels, hypercapnia. We have to adjust the rate. We cannot fix it. And another important thing is we got and high VT. Can you do this high VT that promotes inflammatory response and contribute to acute lung injury? Extremes of weight and female sex are risk factors for inadvertent high volume ventilation. We can choose the ventilation according to the predicted body weight, ideal body weight for the men and women. So regarding this PEEP is concerned, low PEEP, no, sometimes not accepted, and the PEEP value is so much reduced with this, what is written in this slide is less than 2 centimeters of water. We cannot take it as granted, and we have to optimize the PEEP or to zero PEEP. The PEEP ranges from 4 to 7 centimeters of water. And another thing is this postoperative respiratory support with CPAP and high flow nasal oxygen has a major role in prevention of this PPC. There is an insufficient evidence to confirm the benefits of CPAP after major surgery, even though, but so many studies are available, literature is available for CPAP in postoperative period to prevent this PPC. And prophylactic nasal high flow oxygen therapy may benefit high risk cardiac patients with respiratory comorbidity also. And postoperative physiotherapy and mobilization, that is the most important role. And this ICOF is a postoperative respiratory care program that reduces the rates of pneumonia and unplanned reintubation in general and vascular patients. This program starts before surgery with education in leaflet and video format. And this intensive spirometry is prescribed 10 times each hour, 3 to 5 efforts each set during working hours until discharge, with the device always being in reach and after postoperative technique practice. And 4-hourly documentation of incentive spirometry volume occurs. The patient deep breathe and cough every 2 hours. Ideally, the patient sat on the chair or head of the bed is elevated 30 degree with mobilization 3 times a day. These are all the program schedules of ICOF, respiratory care program. And oral hygiene, that is most important thing, maintained twice daily, teeth brushing and mouthwash. And incentive spirometry alone has not been shown to reduce the PPC. After thoracic and cardiac or abdominal surgery, a combination of physiotherapy, yearly mobilization, and oral hygiene and seems to be more beneficial. Okay. And what is this? And analgesia, that is the most important thing. And this analgesia means this epidural analgesia has a major role in major abdominal surgeries and thoracic surgeries. The advantages are improved respiratory function and reduces the rate of infection, pneumonia, postoperative pneumonia, and reduced rate of elective postoperative ventilation and unplanned reintubation. So analgesia has the most important role. And this obese patient, as I already told earlier, more likely to develop OSA leading to respiratory depression. And the dose of opiates should be reduced in patient with OSA. With this, I want to finish this session and this take-home message for PPC. It is a very common in the postoperative period, and the treatment is very costly. That will increase the morbidity and mortality of the patient and will prolong the length of the stay in patient with in the hospital. And for that, you have to understand the pathophysiology of postoperative pulmonary complications, and you have to identify the risk factors by identifying these high risk patients and assess the modifiable and non-modifiable risk. If the risk is modifiable, you can modify it, optimize the patient before subjecting the patient for surgery. And preoperative optimization of the comorbidity is the most important thing to prevent PPC. Correction of anemia is most important because it is a single independent factor for the development of PPC. Protective ventilation strategies, which I have told earlier, you have to apply it to reduce the incidence of PPC. And there is the ventilation strategies that is called protective ventilation, PV. That is low PV, tidal volume, optimal PEEP, and recruitment maneuvers. The recruitment maneuvers, you have to use a maximum up to 40 centimeter of water, and that should be sustained for 7 to 8 seconds. That will re-expand almost all the alveoli in the lung. The most important role in the prevention of atelectasis. And minimizing the surgical time in high-risk patients. That is the most important thing. You should have the very good coordination with the surgeons. And postoperative yearly mobilization, chest physiotherapy, and oral hygiene. These are all, and avoiding nasogastric tubes after surgery that lead on to microaspiration. And the most important thing is and postoperative adequate analgesia. These are all the strategies that we have to follow to prevent postoperative pulmonary complications. Okay, thank you.